Hey everybody, this is the lecture on chapters 32, 33, and 34, hematologic disorders. We're not going to cover everything in each of these chapters, so make sure you pay attention to the objectives and the topics on this PowerPoint, because those are the only things that we're going to be covering. All right, so here's our objectives for all three chapters. We're going to be looking at the different therapies for blood disorders and nursing responsibilities that go along with those problems and blood transfusions. We're going to talk about different types of anemias, talk about how to take care of patients with anemia. We're looking at leukemias and other disorders of blood components, the nursing process related to all of those things, as well as how to take care of patients with these issues. We will not be discussing lymphoma or multiple myeloma, so you can disregard that objective. But we will be talking about leukemias and patients with bleeding disorders. All right, to start off with in chapter 32, we're just going to do a brief review of the hematologic system, what it consists of. You should remember that normal blood volume is approximately 5 to 6 liters. It accounts for about 10% of total body weight. Blood is made up of, it's about 55% plasma, which includes albumin and fibrinogen. Y'all know what albumin is. It's a protein, and fibrinogen has to do with clotting, the clotting process. And then the remaining 45% is made up of red cells, white cells, and platelets. Hopefully you know what each of those components are responsible for doing. So, review that if you're not familiar or can't remember exactly. The blood system, or the hematologic system, is also made up of not just blood and blood products, but the bone marrow and the reticuloendothelial system, which we will talk about a little bit, not in great depth, but we will talk about it briefly. So the hematologic system is made up of all of that, okay? Bone marrow, of course, I'm sure y'all remember, is the primary site of blood cell production. Bone marrow increases production in times of need. It's a response to demand, increased demand. So when you need it, it's going to produce, and when you don't need it, it won't. Primary sites are, of course, pelvis, rib, vertebrae, and sternum. Those are the most common sites in adults. So if you think about, testing that we do for the hematologic system, bone marrow biopsy is one of the primary diagnostic tests that we do. So if you think about these four sites, pelvis, rib, vertebrae, and sternum, which of these four places would be the best place to use for bone marrow biopsy? Where would I want to stick a sharp needle to draw out some bone marrow? Obviously, pelvis is the easiest to access, and probably none of it's comfortable, but the least painful for the patient. Stem cells are also located, all of the blood cells, red, white, and platelets, are all located in bone marrow. Stem cells are also found in bone marrow. We're not going to talk in depth about stem cells, just know that they are those generic cells that later differentiate into specific things. They can differentiate into organs, into specific types of skin cells or blood cells, or just anything in your body. That's everything generates or comes from stem cells initially. So as an adult, you do still have stem cells in your bone marrow, just not as many, but they are still present. Okay, so let's talk about red cells first, erythrocytes. They, of course, I've said, found in the bone marrow. They are formed in the bone marrow. A mature red cell is made up almost entirely of hemoglobin. which is hemoglobin is made almost entirely of iron. So iron is an important component to proper red cell formation. Y'all remember hemoglobin is necessary for us to have a sufficient oxygen. If we don't have enough hemoglobin, then we can't carry red cells, and then we can't carry oxygen. So if you don't have enough hemoglobin, excuse me, not enough hemoglobin equals not enough oxygen. Excuse me. So it's essential that we have enough hemoglobin in our body to carry enough oxygen, and hemoglobin is made up of red cells, so hence we have to have enough red cell production. Red cell production is stimulated by erythropoietin. Erythropoietin is produced in the kidneys in response to a decrease in oxygen. So anytime the body senses a reduction in oxygen, it stimulates production of erythropoietin, and it stimulates a process called erythropoiesis, which is formation and production of red cells. Reticulocytes are those immature red cells, and anytime there is a need, there is increased production of erythropoietin, or anytime there is stimulation of erythropoiesis, then there's going to be an increased number of reticulocytes. Those are the immature red cells. It takes about 5 days for a red cell to mature, and of course blood loss can be faster than that 5-day process. So anytime we're wondering if there is a loss of mature red cells, we can do a reticulocyte count, and that will measure the level of immature cells present in the system. If there's an increased number of immature cells, that signifies to us the body is trying to produce more red cells for some reason. So a retic count or reticulocyte count is very diagnostic when we're looking for problems with red cells. Again, it takes about 5 days for erythropoiesis to complete. So if there is blood loss that at a rate faster than a 5-day process, then we're going to see an elevated retic count. I have to have good iron, iron stores. Iron is stored in the body and released as needed for proper red cell formation, but you have to have iron, B6, B12, and folic acid. All of those things are required for normal red cell production. So anything that alters iron storage or metabolism, or a lack of B vitamin, a lack of folic acid, any of those things are going to alter red cell production. So you need to think about things that alter iron, B6, B12, and folic acid. That's going to be things like malnutrition. A lot of times you'll see in alcoholics where they are malnourished. They're low in B12, they're low in folic acid levels, they're low in iron. That's why we hang what we call a banana bag on people who are known alcoholics or known drinkers, because usually these elements, these vitamins and iron, are lacking. Whenever iron stores are depleted, when you don't have enough iron, hemoglobin production or synthesis is depressed, which means the red cells are going to be very small. We're going to have low hemoglobin levels. So obviously then that can translate into a lack of oxygen carrying capacity. A lack of dietary iron is not really very often a cause for iron deficiency, or things like iron deficiency anemia. Usually when there's an iron deficiency, it is the direct result of blood loss. So there's either bleeding, or has been blood loss for some reason, which has stimulated release of iron, that stored iron, in an attempt to make up for the loss of red cells. So usually whenever we see iron deficiency, it's an indication of bleeding, an active bleed, or blood loss at some point. So That's another way, looking at an iron level, that's another thing that we can do to evaluate if there has been blood loss at some point. B12 and folic acid does come from diet. Iron does too. Iron comes from dietary iron is probably our number one way we get iron, and it is the number one way we get B12 and folic acid. So B vitamin rich diet and folic acid rich diet is very important. Fortunately for us, a lot of things have B vitamins and folic acid in them. So if we're eating a healthy diet, balanced diet, then we're usually okay. Things we have to look out for, B vitamins come from an animal origin or basis. So people who are vegetarians, we have to be very concerned about them. We have to look at that. And then we also have to consider that B12 combines with intrinsic factor in the stomach to be utilized. So patients who've had a gastrectomy or a gastric bypass often have decreased levels of intrinsic factor, so they become B12 deficient. So these people have to be on B12 replacement. It's very important. And there are a lot of patients these days who are having gastric surgeries. So that is something for us to consider as we are moving, as you move into practice. The normal lifespan of a red cell is about 120 days. After that point, it gets filtered out by the liver and the spleen. Most of the hemoglobin and the iron are going to be recycled when that red cell is destroyed. Some hemoglobin breaks down into bilirubin and gets secreted into the bile or feces. And that's what gives our feces the characteristic brown color is bilirubin. And that's going to come back. You will see that come into play or be important later on down the road when we talk about some other disease processes that will alter bilirubin. So again, after about 120 days, the body begins to break down that red cell, and it recycles the hemoglobin and the iron, most of it. Some of it, the hemoglobin does break down into bilirubin. But for the most part, the body hangs on to it and recycles it. Okay, the next thing we're going to talk about are leukocytes, or white cells. They also were formed in bone marrow, and their major job is to protect the body from foreign invasion, protect us against infection, tissue injury, things like that. So there's two main categories of white cells, granulocytes and lymphocytes. Okay? Now, underneath granulocytes, there are several subcategories of the eosinophils, basophils, neutrophils, and agranulocytes. Okay? So it gets a little confusing. Don't worry about each individual thing and the specifics of what they do. I'm just going to hit some highlights, and that's all I'm going to really expect you to remember. So as we're moving through this, don't get lost in the fine detail, okay? I just want you to get the big picture of all this. So our granulocytes compose 60 to 80% of the total white cell count. So the majority of what we have are granulocytes. Again, there are subgroups of eosinophils, basophils, and neutrophils. These subgroups are characterized by how they stain. If you remember in microbiology, y'all talked about how different cells stain and this and that, and that's not what we're here for, so don't worry about it. I'm not going to ask you what color they stain. The main thing I want you to know is that your eosinophils and basophils are involved with things like hypersensitivity reactions, allergic reactions. Eosinophils and basophils are released in response to allergic reactions, and they help to neutralize that histaminergic response, or to neutralize histamine. Okay, we're going to revisit that in another lecture when we talk about the immune system. Okay, so just tuck that away for later. Eosinophils and basophils have to do with hypersensitivity and allergic reaction. Neutrophils, their main function is phagocytosis. So they're the ones that are going to act first, act quick. They're released very quickly in response to a foreign body, usually within the first 6 hours. They're the ones that are going to be sent out first. They're kind of the Navy SEAL or the Marine Special Forces. They're going to go out first, attack first, and try to get that foreign invader under control. And their main job, like I said, is phagocytosis. There is a particular part of the neutrophil. The book goes into detail about band cells. I'm not going to really spend a lot of time on that. You just need to know that neutrophils act first, usually within 1 hour of onset of the inflammatory response, definitely within the first 6 hours. They're very short-lived. They die very quickly. Okay. The agranulocytes are monocytes. Those cells evolve eventually into macrophages, and that is actually the second line of defense in our process of defending against invaders or infection. So we're going to have the neutrophils first, act quick, and then macrophages come on. They come in line second as the second line of defense. They live longer. They have a longer protection, especially against things like viruses and fungus. So they're going to be the ones that do the prolonged defense. And they also, monocytes also help to digest old blood cells. So when we were talking before about how the body breaks down old red cells, monocytes are a very active process, or part of that process. Okay, so again, there's two main categories, granulocytes and lymphocytes. So everything I've talked about up to this point kind of falls under the granulocyte category. Even though agranulocytes are not granulocytes, they are different, they still kind of lump all that into one category. Okay, so the next thing I'm going to talk about are the lymphocytes. Those compose 20 to 40% of our total white cell count. Our lymphocytes are a mature lymphocyte is the basis of our immune system. Its primary job is to attack against foreign material. Okay. Other functions that they do, lymphocytes are primarily responsible for forming antibodies, and to help identify and remember foreign substances, so that if those substances show up again, our body knows to attack them. Okay, so that's the function of lymphocytes. Now there are two types of lymphocytes, T lymphocyte and B lymphocyte. And at this point, all you really need to know is that the T lymphocytes come from the thymus gland, and B lymphocytes come from the bone marrow. Again, we're going to get more into lymphocyte specifics when we talk about the immune system. The T lymphocytes eventually will evolve into what's called helper Ts and killer Ts, and that plays a role in immunity. We're not going to discuss that in this lecture. All I want you to know at this point is that your lymphocytes are the basis of the immune system. A mature lymphocyte they are the basis of the immune system, with a primary role of attacking foreign material to produce antibodies so that we can identify and remember foreign substances. Because we have that part of our immune system. The immune system has two parts. The part that identifies and remembers foreign substances, and then there's a part that doesn't remember foreign substances. So again, we'll get more into that in immunity. The last thing we're going to talk about are the thrombocytes, and those are your platelets. Okay, so Guys, if you will just remember your prefixes when we're talking about all of these disorders, not so much with red cells, but with the white cells, if you can remember lymphocyte, lymph, leukocyte, leukemia, that's white cell, and then thrombocytes, thrombocytopenia, things like that, that will help you identify what type of cell is involved in the disorder. So thrombocytes are platelets, and of course their role, their primary function is to control bleeding. They circulate at all times. They help to maintain vascular integrity. They will collect or clump together actively at any site of vessel injury to adhere to the vessel, and then they begin to adhere to each other to form a temporary platelet plug to control whatever bleeding is happening. And then in this process, as this temporary platelet plug is formed, it activates other clotting factors in that whole clotting cascade, which is primarily made up of fibrin. And then that triggers formation of a fibrin clot, which is much more stable and much more long-lasting than that temporary platelet plug. Okay, so just understand that thrombocytes or platelets are essential to control bleeding, and it's kind of a two-step process. It's really not two steps, it's way more than that. But for our purposes, what I really kind of want you to get out of this is that there is an initial platelet plug. Whenever there's injury, platelets immediately are dispatched to that area. They stick to the vessel or the area of injury, and then they begin to stick to each other, and that forms a temporary platelet plug. And then in that process, the whole clotting cascade is activated, and that more permanent fibrin clot will begin to form on top of the platelet plug, which will give a more stable and long-lasting form of bleeding control. Okay, the next section we're going to talk about is plasma and plasma proteins. Of course, you know that plasma is just the liquid part of the blood once all of our cells, other blood cells, are removed. Plasma is about 90% water and about 10% what I call other stuff. And the other stuff is made up of plasma proteins, okay? And that's going to be your albumin. Y'all know what albumin is. It's a protein, helps to maintain fluid balance. Plasma or the other stuff is also made up of A and B globulins, which are responsible for transportation. They carry bound substances. That just means that they are carriers. Things bind to these globulins, and the globulins transport these other things through circulation to the appropriate place in the body. Okay, I'm not going to ask you to know what things those are. I just want you to know that the A and B globulins are the transport vehicles. Okay, so they help to carry things throughout circulation into the appropriate parts of the body. G globulin or gamma globulin, or also we refer to it as Ig antibody, has to do with immunity. So that is also some of the other stuff. It's in that 10% of other stuff. Clotting factors, fibrinogen, is in that other stuff, and then enzymes and waste products. So our plasma is, it's pretty important. 90% water, 10% other stuff, but that other stuff has some very important parts to it, okay? Albumin, alpha, beta globulin, gamma globulin, clotting factors, and enzymes and waste, okay? Serum is what's known, it's what we refer to in medicine as plasma without the clotting factors. So anytime we don't usually give patients a transfusion of serum, but if you hear that word serum, that's what that means. It's just plasma with no fibrinogen or other clotting factors in it. The RES system, we talked about that in the very beginning. It's the reticuloendothelial system, which is a specialized system composed mainly of macrophages. And these macrophages are substances that can live for a very long time. They can live within your tissues for months to years. Okay, so the RES system is just another specialized system that is part of our defense mechanism. Its function, the RES system's function, is to defend against invasion of foreign substances. It has a part in phagocytosis. It also helps to remove those old or damaged cells from circulation. It stimulates the inflammatory process. It has an active part in stimulating inflammation. Um, It is a component of other organ systems, particularly the spleen, lymph nodes, lungs, liver. So, and don't get caught up in the specifics of the RES system. I want you to have a basic overview of what it is, what it does, and why it's so important. So if I talk about the RES system, I just want you to know that it's it it's a long-term defense against foreign substance. Okay, um, the spleen is the major player in the RES system. Okay, the spleen is the major site of activity because the spleen's purpose is to filter out old immature red cells from circulation, and then the spleen also um, plays a role in our clotting and our immune system. Okay, we're not going to go in depth in that. I just want you to understand that the spleen plays a role in filtering out red cells, clotting, plays a role in clotting properly in active, healthy immune system. So a person who is without a spleen can have issues with clotting disorder or not clotting as quickly, and then they can also have reduced immunity, so they're more prone to infection. So if you just kind of, again, big concepts, don't get caught up in all of the little details in the book about the reticuloendothelial system. Just hit the high points, kind of what I've mentioned here. Hemostasis, another process we're going to talk about real quick. Of course, process of preventing or stopping blood loss. Two types of hemostasis, primary and secondary. Um, of course, to have hemostasis, you have to have a good number or an adequate number of functional platelets. And the key here is functional platelets. We can have enough, we can have circulating platelets, but if they're not functioning properly, then we're not going to have good clotting. So in order for them to function correctly, in order for platelets to function, we've got to have not just a normal number, but they've got to be normal functioning. Okay. Primary hemostasis is, like I talked about before, whenever there's an injured vessel, platelets are dispersed there. We get that initial platelet plug. It's a very unstable clot. It is not meant for long-term hemostasis. In the process of the platelet formation, platelet plug formation, it triggers secondary hemostasis where fibrinogen is released, and that leads to the formation of a fibrin clot. A fibrin clot, formation of a fibrin-based clot on top of that initial platelet plug is that process of secondary hemostasis. Now, as this process continues, that stable fibrin clot will stay as long as it's needed. And then once that site of injury begins to heal and that fibrin plug is no longer needed, then the body senses the healing. The body, it's just a fabulous process where the body just knows that fibrin is no longer needed, that clot is no longer needed. So then it begins to stimulate production of plasminogen. And once plasminogen is activated, that's the body's signal. We don't need that fibrin clot anymore. And plasminogen begins to break down or lyse the fibrin. Um, the plasminogen is actually part of the clot, and it becomes active when the fibrin clot's no longer needed. And then as that clot breaks down, as the fibrin breaks down, it breaks into little pieces or byproducts that are released, and these are known as fibrin degradation products. And so that's how the body breaks down that clot. Plasminogen is stimulated, and then plasminogen begins to break down the fibrin clot into byproducts known as fibrin degradation, or FDPs. Those FDPs are then released into the body, into circulation. They are actually reabsorbed by the body. But this wonderful process, as it's taking place, guess what we can do as practitioners? We can check blood levels of fibrinogen and fibrin degradation product. We can actually draw blood samples to measure the levels of those, and that tells us whether or not the patient is trying to break down a clot. So think about, we talked about this in class the last time we met, about DIC. So when we are evaluating a patient for DIC, a fibrin degradation product and a plasminogen level are things that we might be looking for, because we talked about how DIC is microclots in the body. Well, FDP is going to be present if the body is attempting to break down clots. So that's another important lab test that people are going to be checking in patients if we suspect DIC, or if they have had an injury that is healing, and we see that fibrin clot is no longer necessary. We're going to see increased levels of FDP. All right, our diagnostic evaluations, we've already talked about a lot of this. Of course, CBC is probably the most common. The thing to remember about these diagnostic tests is that abnormalities can be either an absence, they can be either a disorder or a lack of quantity, meaning there's not enough of the actual cell, or it can be a dysfunction of quality, meaning that we have enough cells, but they just don't work properly. So our diagnostic testing is going to be aimed at determining, is it a quantity problem or a quality problem? So again, CBC is going to be probably the most common that you're going to see. A lot of times our patients are asymptomatic with these types of disorders, and in a CBC or the PT-INR, whatever, is the only way that we know that there's a problem. So our CBC with a differential, meaning that it specifies each particular type of cell. It's going to give us the total number of cells, eosinophils, basophils, neutrophils, hemoglobin, hematocrit, platelets, gives us the total number of each specific type of cell individually, and that's called a differential. A CBC with differential, and sometimes they'll do what's called a manual differential, where the lab actually physically looks at a slide of a person's blood cells underneath a microscope, and they physically count the number of red cells, the number of white cells, the number of platelets. That's termed a manual differential. Of course, PT, PTT, INR would have to do with our platelets and our clotting factors. Hemoglobin is going to be, the amount of hemoglobin, the actual amount of hemoglobin, which is measured in grams. And then the hematocrit is the percentage of red cells that are in the total blood volume. So it's kind of a volume percentage. So the lower the hematocrit, the lower the percentage of red cells in perspective of total blood volume. Another test that we do frequently is bone marrow biopsy or bone marrow aspiration. Of course, used to assess more specific information about cells. Again, it's going to give us information about quantity, how many are being produced, the quality, shape, formation, functionality of those cells. It is performed in adult patients. We take the biopsy or the aspiration from the iliac crest, and it's usually done under moderate sedation. It's a sterile procedure, so you need to go back and review the process for bone marrow biopsy. I believe this page number on here is in the old book, in the old edition. So I think in the 13th edition, I think your new textbook, the green and white one, I think it's page 888. And it talks about nursing care of patients after bone marrow biopsy. Okay, so go back and review that on your own. Make sure that you review the process for bone marrow biopsy, risks associated with it, and nursing care associated with it. Of course, bleeding is going to be our number one concern immediately post-procedure, so you need to review nursing considerations, what to do immediately after the procedure, patient care immediately after, things that you need to be aware of, types of medicines. If your patient is on certain types of medicines, they might have an increased risk for bleeding. If they have a decreased platelet count, what does that mean for them? Patient teaching about post-procedure care. You know, how are you what kind of instructions are you gonna give them when they go home? What if it hurts? You know, what if it gets red? You know, what kind of things are you going to tell them to look out for? So make sure y'all review all of that. Some considerations for older adults or elderly, age-related considerations to think of. There's decreased bone marrow production in an older adult. Oftentimes that can be from just being on certain medications. It can lead to bone marrow suppression. So I want you to think about what types of medications that a patient might be on that would lead to bone marrow suppression. That just, simply means they can't produce enough red cells, white cells, platelets, whatever, to meet the need that their body has. So there are lots of medications that we use to treat other disease processes: COPD, rheumatoid arthritis, autoimmune disorders, allergic reactions. There's a lot of different medications that we use to treat these disorders, these other comorbid conditions, and they lead to bone marrow suppression. So, think about that, because as we move into these next few weeks, we're going to be talking about the immune system and bone marrow suppression and things like that. So it's really going to, I think, come together for you, but begin to think about that now, and that'll help you down the road. Management of our hematologic disorders, splenectomy. Splenectomy is going to be the number one therapeutic approach. Removal of the spleen. Like I said, the spleen plays a major role in destruction of red cells, clotting, in the immune system. So if we have to remove the spleen, it puts your patient at risk for increased risk for infection. Another treatment they can do is called therapeutic apheresis. where it's similar to the process that you would donate blood, but actually what happens, the patient will they'll actually access both arms, and so they take out a pint of blood basically, and they apherese, or they remove the individual blood components. So it could be red cells, it can be white cells, or it could be platelets. And the specific component that's removed refers to the type of apheresis it is. So we can do platelet apheresis, we can do leukapheresis, and that just specifies the type of cell that we're pulling out. Typically, when they do this, a person who donates for this, they will remove the component that they need, and then they return the others back to the patient in the other arm, so that we are not depleting the donor of products that we don't need. So splenectomy, therapeutic apheresis, stem cell transplant is another approach to managing these hematologic disorders. It is a cure in some cases. Can be stem cell transplant can be autologous, meaning we can use the patient's own stem cells, or it can be allogenic, meaning that we have matched the patient with donor stem cells, and this donor stem cell transplant tends to be much more effective than autologous. I don't know why. We're not going to go in depth into stem cell transplant. There's some information in the book, and I'm sure it's interesting to read. Not going to ask you a lot of questions about this. I just want you to understand, I want you to know that stem cell transplant is a method to treat hematologic disorders, specifically leukemias. Okay. Therapeutic phlebotomy is another approach that will be used, and that is what we call bleeding the patient. Typically, you may not see this very often. It's usually done in disorders where there is an overproduction of hemoglobin and hematocrit, which would be polycythemia or hemochromatosis, where the patient is producing too many red cells. We'll actually bleed the patient or remove some of their blood volume. And then probably the most common thing that you're familiar with is blood component therapy or transfusion therapy to treat hematologic disorders. We can give whole blood. Whole blood is basically 450 mils of blood component and about 50 mils of anticoagulant to keep it from clotting together in the bag. Or we can give individual components, red cells, white cells, platelets, plasma. That blood volume is usually 250 to 300 mils. We don't give whole blood very much anymore at all. Typically now what we give are individual components. If we give blood, it's usually just packed red blood cells. Okay. They are easier to store. Red cells have to be kept, packed red cells, PRBCs, have to be kept refrigerated. The storage and viability of each component is different based on the particular component, but red cells have to be kept refrigerated. Platelets are usually kept at room temperature. Well, they're kept in the refrigerator until we're ready to use them, and then they're going to warm them up, because if you don't warm them up, they stick together. They're platelets. They're going to clump together. So they have to be at room temperature before we give them to the patient. And I say they keep them in the refrigerator. I think actually, I don't know what the book says. Of course, testing-wise, go with what the book says, but I really think that LifeShare actually freezes them until they are ready for administration, and then they thaw them up. And from that point forward, they have to be kept at room temperature. Plasma is frozen, and that might be what I'm thinking of as plasma, not platelets. So don't get caught up in all of this. The only thing that I'm definitely wanting you to know about in terms of storage is red cells. Packed cells have to be kept refrigerated. They cannot be out of the refrigerator longer than 30 minutes. So we're going to talk about this again in a minute when we get into administration. But platelets have to be at room temperature. Plasma has to be kept frozen. Plasma and FFP is the same thing. FFP stands for fresh frozen plasma. So it must be kept frozen at all times until we're ready to give it. In terms of viability, we're going to discuss that more when we get into administration of blood components. Okay. So special preparations, clotting factors. We can give individual clotting factors if necessary. Human albumin, that's just the albumin that you and I have in our blood system. And then immune globulins. So each of those factors, clotting factors, albumin, and immune globulins, can be removed or filtered out of the blood and given on an individual basis as a patient needs it. Okay. Globulins are obtained from pooled plasma and used to treat specific allergic disorders or autoimmune disorders or viral problems. I mean, we can use gamma globulin for a lot of different things. And then the albumin is, I mean, that's where we get albumin from. So if you've given any albumin in clinical, that's what it is. It's human albumin, and it comes from blood donation, basically. All right, blood products. The way that we get them, of course, is blood donation. Criteria for blood donation is on page 889. Screening process, all of that, you need to make sure you review that. It is a very strict screening process at this point. Prior to 1985, patients who received blood donations prior to 1985 have a much greater risk of acquiring HIV, hepatitis B and C, because we did not screen blood products and blood donation as strictly before 1985 as we do now. The different types of donation: directed, standard, autologous, blood, intraoperative blood salvage. We're going to talk about all of that stuff. We're not going to talk about hemodilation, so scratch that off your list. Directed donation just means that you can go into a blood donation center here in our area. It's called LifeShare, and say that you want to donate blood for a specific person. It's not that it is safer, it's just you are giving blood for a specific person. Now, that does not necessarily mean that you have to be a type, a match for that person. You can actually go into LifeShare, and if the person you are donating for is B positive and you are AB negative, then what they'll do is they will take your unit of blood, they will, and then in turn they will take a unit of B positive blood that they already have and designate it directly for the person that you have donated for. So it's kind of like making sure that the person you're donating for has blood ready and available. We see this a lot in patients who are going to have big surgeries, big planned surgeries where we know blood is going to be necessary. They can ask people to donate, and they can go in, donate a unit of blood, and it is directed for a specific person or a specific recipient. Standard donation is just your regular standard blood drives. Y'all know about all of that, where you have to, meet criteria to receive donation. But that blood is put into the what I call general population. Anybody that is a match for your blood type is eligible to get it, and it is not specified or directed to go to one recipient. Autologous donation is where the patient goes in and donates their own blood. They collect their own blood for future use. You can review the advantages and disadvantages of autologous donation. I think it's on page 890, kind of goes into that. Again, patients who know that they're going to be having a big surgery where blood's going to be necessary, they can go in a month, months ahead of time and begin to donate a unit or 2 units. Now understand that, especially with red cells, that process, it's 120 days. So they recommend that patients go in a few months in advance so that we don't deplete their stores before they have a major operation. We will see autologous donation done frequently in patients that are having like total knee replacement or any kind of other big surgery where we know there's going to be blood loss. And it's just, the patient's own blood. So of course there's it's safer. There's no risk of rejection in that case. Intraoperative blood salvage. I've talked about this in class, I think before, where we use the machine or the system called Cell Saver. It's used during surgery, actually during the process of surgery, in addition to autologous blood donation. And that it just means that as the surgery is going on, the personnel, as they're using their suction yonkers and things, that they actually are sucking the patient's blood from the surgical field. It can only be from a sterile cavity. We can't use blood from the GI system or the colon, because that's not a sterile environment. So it has to be a sterile part of the body, a sterile cavity. But they'll take that patient's blood and they'll filter it through the Cell Saver, and it'll wash it out. It'll remove any fluids, irrigation or medicines or debris, anything that's, shouldn't be there. It'll wash it out, and then we actually give it back to the patient as an autologous donation. So it's a really neat thing. Intraoperative blood salvage, it really cuts down on the amount of blood transfusions that people have to have in major surgeries. So, and again, we're not going to talk about hemodilation, so just ignore that. Blood transfusions, just a little bit of review. You might have talked about this in anatomy and physiology, but we're going to kind of go into some specifics here. Of course, pre-transfusion, you need to know about their history and a physical assessment. Why do they need the blood? What's going on with them? What kind of health problems do they have? Physical assessment, how do they look? What is their H&H? Do they have a history of comorbid conditions? You need to know specifically about CHF, hypertension. Do they have renal failure? Anything that is going to have an influence on fluid status or volume status. You have got to be aware of that history, that comorbid history, before we give blood. Patient teaching. Before you begin a blood transfusion, you've got to educate them on signs and symptoms of reactions, what they need to report to you, if they begin to itch, if they get hot and flushed, if they get short of breath, anything that's not normal. You've got to talk to them about that before you start the transfusion. Of course, you have to have a physician order to transfuse blood, and you must have a signed consent as well, so you've got to verify those things. You must have a patient sign a blood consent, and preferably you need to do it ahead of time. So if you think there is a situation, a surgery or a procedure where the patient might require a blood transfusion, you should go ahead and consent the patient ahead of time. That is not something that we take upon ourselves to do. The doctor must order that, just like he would order consent for any procedure. But if it's a big procedure and you think that blood might be required, then our job is to advocate for the patient and ask the doctor, hey, do you want me to get a blood consent too? Just to be on the safe side. So that's a big thing now, is getting a consent form. Used to, we would just transfuse people without consent, and we can't do that anymore. Back when I first started, we never got a consent form for blood products. If the patient needed blood, it was usually an emergent situation, and we just did it. There wasn't really any planning ahead, and of course now medicine has changed, and that is no longer acceptable. You must have a current blood type, and cross match. And what that means is, just a brief review. Of course, blood typing, patient AB, O, the ABO group, and then are they positive or negative? And then cross match has to do with antibody screening. All blood, once the patient is typed and their Rh positive or negative is determined, then they will cross match the patient for antibodies. They will determine if the patient has any existing antibodies in their blood already that could potentially react to a transfusion. So, that's very important, because that's where blood transfusions come from, is when a patient reacts to antibodies that are present in the donor unit. So, that's an important part of that type and cross match process. Type and cross match is good for 72 hours. That is a standard across medicine in the United States. So if your patient has been typed and crossed, it is important for you not only to know the date that it was done, but the time of day that it was done. And it is kind of a facility thing. You need to see. Some people say if the type and match was done today is March 12th. So if it's done today, it doesn't matter what time it's done today, it is good for 72 hours, which would be 12 to 13 to 14 to 15. So that type and match would expire at midnight on March 15th. There are other facilities that say, no, that type and match was done at 10 a.m. on March 12th, so it will expire at 10 a.m. on March 15th. So you need to be aware of your facility's policy, okay? But it's only good for 3 days, 72 hours. So if it's the third day, if it's that at the tail end of that 72 hours, and your patient is headed to surgery, and you know that they're probably going to need blood, then we need to advocate for our patients and have that type and match redone and have blood ready before they go to surgery. And that is, that's something that we can ask about. We can't just do it on our own, but we can ask the doctor about it. So during the transfusion process, if you'll look on page 892, chart 32.2 kind of goes over the transfusion process. Must be verified by 2 nurses. Check your policy, because a lot of times it says 2 RNs. It is not within the scope of an LPN to administer blood products. And so many facilities will say that it is not within their scope of practice to verify blood. So 2 RNs must verify the unit of blood against the patient's blood band, not their hospital armband, not against the MAR, against the patient's blood identification bracelet. Okay? And that should be done at the bedside. 2 nurses, unit of blood, patient's wristband at the bedside, not checking the two nurses with the unit of blood at the desk, and then one person goes in the room and does the wristband. That's not how it should be. 2 sets of eyes on the blood and on the wristband with the patient in the room. Of course, we only give saline with blood. You never run anything else with blood products, only normal saline. Don't ever push medications through blood, a line that has blood infusing through it. If you only have one IV site and you have to give blood products, then you need another IV site. If you can't get another one, then you have to stop the blood transfusion, flush the line thoroughly, give your medicine, and then resume the blood. But you need to bear in mind that you cannot put a blood transfusion on hold for an extended period of time. Once you get that unit from the blood bank, you have 30 minutes to initiate that infusion. And then once it's running, it really should never be stopped at all. I have had to put it on hold briefly to give Lasix or something like that, but no more than 5 minutes tops. And then it should be resumed. And that's because the blood will clot. The longer it sits, the more it's going to clot, be prone to clot. So we got to get it started within 30 minutes. If you can't initiate that infusion within 30-minute time frame, you need to return that unit to the blood bank. And it needs to be returned within that 30 minutes. It can be out of the refrigerator for 30 minutes. If it is out longer than 30 minutes, then that unit of blood, the whole unit, has to be wasted. So keep that in mind. Of course, frequent vital signs. Once the infusion is initiated, then we're going to do vital signs and temperature every 5 minutes times 3. And then usually you can go to Q15. Again, you need to look at facility policy on how this is to be done. But the standard initially is Q5 minutes for 3 sets of vital signs. And that's vital signs, heart rate, blood pressure, and temperature. Temperature is vital here. We have to be assessing for complications. We're looking for signs of reaction. Typically, we're going to start the infusion at a slower rate and then monitor the patient's response, and then you can increase the rate a little bit if we know that the patient is tolerating it well. But the transfusion needs to be completed within 4 hours. So, you've got a unit of blood that's approximately 250 mils. A lot of times, a doctor will order a unit of blood to run. Sometimes they'll just do a rate. They'll do like 50 mils an hour. Well, if you do that, you're going to be pushing the 4-hour limit. So you kind of have to keep that in mind. Hopefully, the doctor's going to transfuse 2 units of blood over 3 hours each, or transfuse 2 units of blood over 4 hours each, or 1 unit of blood over 3 hours, or something to that effect. And you can kind of titrate the rate of the infusion according to the patient's tolerance, okay? But you've got to be done with each unit has 4 hours. So if you've got to give 2 units, then you got to have them both in under 8 hours. That doesn't mean you run the first one over 6 and the second one over 2. It's got to be 4 and 4 or less. And when I say tolerance for the patient, I'm meaning making sure they don't spike a fever, they're not short of breath, they're not getting fluid overloaded, they're not developing fever and chills, just things like that. So if they're doing okay, you can increase the rate of infusion. Just because they've had blood before does not mean they will not have some symptoms or reaction. So every time a patient gets a blood transfusion, you have to treat it as if it's their first time. Tubing changes are required in between units of blood usually. So again, check your facility policy about how long blood tubing is good for. But usually blood tubing is good for the same amount of time that the unit can hang. So typically you have to change the tubing in between units. And then documenting those vital signs frequently. FFP can be administered fairly quickly, over 30 minutes to an hour. Again, it's not a big volume. FFP is usually not a big volume, but you can give it quicker because there's not as much chance of reaction with FFP. But you still have to watch the patient for signs of overload. And then platelets we just give platelets as fast as the patient can tolerate it. We just let them run in, basically. As long as we're not worried about overload, fluid issues with the patient, you can just open it up and let it run wide open. You don't run them slow because they're going to clump. If you run them too slow, they're going to clot off, clot your line, clot your IV, and then you won't be able to use that unit of platelets. So, usually those are administered very quickly. Sometimes things for you to just to know about, in the book some, our FFP and platelets. A lot of times will have different colors to them. Usually they should be kind of a yellow cirrusy color, but sometimes the platelets especially can have a green cast or a green tinge to them, and that's a sign that the patient was a female and that they were on oral contraceptives. That is not a problem. You can still administer those units. That's just a sign that the patient was, like I said, a female and was on oral contraceptives. Some complications of blood transfusion are our reactions. There's different types of transfusion reactions: febrile, acute hemolytic, allergic, circulatory overload. Those are some things that we're going to go over real quick. A febrile non-hemolytic reaction is very common, and it's really a harmless type of reaction. It is very common in patients who have had transfusions before, especially if they have anemias and they're coming in for transfusion on a regular basis. Febrile non-hemolytic is very common in these people. It's very easy to avoid if we will pre-med the patient with Tylenol and Benadryl, usually is what we give. So a lot of times you'll see the doctor write an order for transfuse 2 units, pre-med with Tylenol, pre-med with Benadryl, and that's just a very common treatment to prevent a febrile non-hemolytic reaction, meaning that they're going to run fever, probably going to run fever during this transfusion, but non-hemolytic means that it doesn't clot. So normal, common, harmless, not a big deal. It's actually a reaction to the white cells in the donor unit of blood. Something that's pretty common in this area is for the doctors to order leukopoor red cells, meaning that the white cells are filtered out of the unit of packed red cells, and that will reduce the probability of the patient developing a febrile non-hemolytic reaction. It's the most common type of transfusion reaction that you're going to see. That doesn't mean you have to stop the transfusion. Now, if you have a patient you're giving blood to and they do spike a fever, low-grade fever, and start to feel weird, a fever is the first sign of reaction. So, of course, the first thing you do is to turn off the blood and open up the saline wide open. And then treat the patient, assess them, treat them if necessary, notify the physician. A lot of times, 99% of the time, it is this febrile reaction. So we just give a dose of Tylenol, give a dose of Benadryl, and the doctor will tell you to go ahead and resume the transfusion. Second complication or transfusion reaction is the acute hemolytic reaction. That's the bad one. It's the most preventable type of reaction, but it is the most deadly. It is a direct donor incompatibility. So most preventable because we type and screen our patients. And if we have done that properly, followed the proper policy and followed the steps the way we're supposed to, and verified our unit of blood and verified our patient, then we will not give them an incompatible type of blood. So it is easily preventable. The donor incompatibility, meaning that either the ABO group or the RH factor is incompatible, and it causes a very rapid intravascular hemolysis, where the cells are just broken down. It does cause fever first. That is the very first sign, accompanying with back pain, chills, chest pain, shortness of breath, a rapid drop in blood pressure, shock-like state. Okay, hemoglobinuria. It's a very, very rapid deterioration of your patient. Okay, so again, that's why we check temperatures so frequently in a blood transfusion, because a fever is the first sign of a reaction, and it is the first sign in both of these types of reactions, non-hemolytic and hemolytic. So, a fever in a patient receiving blood should never be taken lightly. It should always be assessed. It should always be reported to the physician, okay? Again, in the acute hemolytic reaction, if you're noticing these signs in your patient, fever, chills, chest pain, shortness of breath, shock-like symptoms, immediately terminate the transfusion. Just clamp it off, open up the saline, let saline run wide open, assess your patient, treat your patient as they need to be treated, have someone notify the doctor. This is a very rapid and critical thing that needs to be addressed. The third type of reaction is an allergic reaction. That's just your classic allergic symptoms, itching, hives, flushing, but it can be severe all the way to an anaphylactic type response. So it can include shortness of breath, profound swelling, hives, flushing, and that can lead to anaphylactic shock, signs of low blood pressure, shock-like state, okay? Again, this type of reaction can be avoided with pre-treating the patient with Benadryl to kind of stop that allergic response, okay? But once again, temperature, vital signs frequently during initiation of the blood, okay? If there are any signs of these problems, stop the blood, clamp it off, open up the saline wide open, treat the patient, notify the doctor. Other problems or complications that we have to assess for with blood transfusion is circulatory overload. If you give blood too fast, they're going to go into overload, even if they have relatively healthy heart, lungs, kidneys. In the elderly population, especially age-related considerations, if we give them too much volume too fast, they can go into fluid overload. If they have heart problems, CHF, reduced ejection fraction, a degree of kidney injury or kidney failure, COPD, anything like that, we have to really, really monitor how quickly we give them this fluid, this blood. So it is essential, it is vital that you monitor their circulatory status, not just in the beginning, but throughout the entire transfusion. Transfusion reactions will happen early on in the process. They will happen almost immediately after you begin the transfusion. Circulatory overload doesn't develop until later in the process, once they have this volume on board. So that's why it's very important that you monitor the patient throughout the whole process. Other complications, disease acquisition. If you will look on page 896, there's a chart 32.4 that talks about diseases that can be acquired from blood transfusions. Not common anymore for us to see this, but it is a possibility. Hepatitis, HIV, cytomegalovirus, Hep B, Hep C, can still occur. So make sure you look over those things. And then complications of long-term transfusion therapy are just increased risk of infection and then development of antibodies. Like I talked about earlier, whenever we're doing the type and screen, patients who receive multiple blood transfusions, and that would be someone who has an anemia or something like that, that we're having to give transfusions, say once a month or every 6 weeks or on a regular basis. The more they are exposed to donor blood, the more likely it is that they will develop antibodies to things that are in that donor unit. And so the more antibodies that the patient develops, the greater the likelihood it will be that they will react to a transfusion. So, a lot of times these patients have to be screened ahead of time because it can take a while. It can take a day or so. If a patient has a lot of antibodies, each one has to be identified, and they have to make sure that they wash the donor blood of any of those antibodies, any of those antigens, so that they don't cause a reaction. So, that's just a complication for people who are on long-term transfusion therapy. All right, our responsibility, nursing management related to reactions. I've talked about this. If you suspect a reaction, stop the transfusion. Just turn off the blood, clamp off the line, open up your saline, keep your IV running. Initially, we will open the saline that's running with the blood, and then ideally you would get a new bag and new tubing to flush and keep that IV going. Take care of the patient, assess them, treat them for anything that they need, call the doctor. And then most facilities have a process that say if the patient is having a reaction, that you need to notify the blood bank and return whatever blood is left, whatever unused portion in that donor unit, and the tubing needs to be returned to the blood bank so that they can do testing on it. And then our responsibility too is to get any lab work that might be ordered by the doctor, or if the blood bank needs certain lab work collected from the patient, if we're trying to rule out a hemolytic reaction or bacterial contamination, something like that, then it's our responsibility to make sure that those orders get carried out. Okay, so stop the blood, open up your saline, treat the patient, assess and treat your patient, notify the physician, and then send the blood back to the lab.